Yeah, welcome to Decoding CTO case 9. Today I am bringing a case of right coronary artery instant total occlusion. I am Dr. Sharath, interventional cardiologist from Medicover Hospital. My patient is a 69-year-old male, status post-PTCA to LAD and RCA 5 years ago. He had stents in proximal and mid LAD as well as mid RCA. He came with exertional angina despite optimal medical therapy, limiting his quality of life. He had normal sinus rhythm, good LVRV function, and his stress test was positive, and he's hypertensive. So as I don't have angiogram, I'm showing dual angiography directly. So you can see here, so RCA is total occlusion, instant, proximal to mid, and left system is filling nicely, and there is a patent stent in mid and proximal LAD, and there is a good epicardial coronary coming from LAD, filling PDA almost instantaneously. So it's a major epicardial collateral. So this is the anatomicogram of patient. So this is a stent which is occluded. You have a little proximal cap is within the stent, and also distal cap is within the stent. So both caps are within the stent, and this is a stent in proximal LAD which is patent, and mid LAD which is patent. L6 is non-dominant and RCA is dominant. So coming to the wiring strategy, so as in this case it is isolated total occlusion of stent within RCA. So we can go ahead directly with a CROSSBOSS as a primary crossing strategy. If this doesn't happen, if CROSSBOSS won't progress, then we can go ahead with antegrated wire escalation approach, or even a knuckle wire approach. Or if it doesn't work, probably even we can take retrograde through epicardial collateral, so which is there from LAD. Coming to the challenges in this case, it's a very proximal CTO, and there is no side branch. You can see here the conus is coming from the sinus, it's not coming from RCA, so it's not useful for anchor balloon technique. So we may need to use a good support guide, that is AL, and we can't use anchor here. So that's the only challenge. And coming to dual injection, yes, which already I discussed. So there is a CTO almost 70% of the stent. So what we did, we went ahead with the CROSSBOSS positioning. See, we can see here. So with Workhardt's wire positioned into the proximal stent, then we advanced CROSSBOSS. This is CROSSBOSS into the proximal cap. Cap is within the stent. So this is a key. So whenever we are using CROSSBOSS, so we have to position CROSSBOSS within the stent. We shouldn't do spin advancement proximal to the stent stud, because it may go into subintimal area outside the stent stud. So always start spinning within stent studs. That's a bottom line. So, and we started doing spin advancement like this. But what happened is the support is not great. The gate catheter is popping out, and there is no advancement in CROSSBOSS despite significant time. So next we went ahead with antegrade wire escalation with the balloon trapping of microcatheter. As guide was jumping off. You can see here, so I trapped microcatheter. This is CORSAIR, and there is a 3mm balloon, so which is trapping CORSAIR, and then I am advancing a pilot wire. So this is a pilot 200 wire, you can see, and I am checking angled views to see whether the wire is within struts in all the angles, or is it going out of the strut. So it appeared it is within the struts in all the views, all the angles. Yeah, this is what we are checking. So we are checking in all orthogonal views for wire position. I was convinced, but beyond this point wire was not advancing, so it struck at this point. But angiographically wire actually reached distal true lumen at this point, so it was supposed to go freely, but it's not going. So most likely, what is the reason for stalling of antegrade wire escalation and also balloon uncrossability in this case? It could be an underexpanded stent here, so which is preventing balloon to go down, as well as even holding wire so that we are not able to advance, or the wire must have gone through a strut at some point, so which is not allowing wire to progress further, or there can be a neoatherosclerosis with calcium here, so which would have prevented wire going across. So we switch to knuckle wire technique. So how knuckle wire technique helps here is, so when you are doing a knuckle wire, in fact you are going to break the tissue across, and you are going to create a space so that your next devices will easily track over the wire. So that's what we planned, but to do a knuckle wiring in this case, we need immense support to guide catheter, so which we achieved with the balloon trapping of microcatheter here, so as showed here. So that's what we did, because it's a very proximal CTO, so and you won't get much support for knuckle wire in that situation. So you can see here, so I trapped CORSAIR with a balloon side by, and then we advanced knuckle wire. I think this is a gladius wire, so knuckle, so we advanced knuckle wire, so which I am checking both in LAO as well as RAO to see that knuckle is going through the stent struts. So knuckle went up to this point, and once knuckle got advanced, generally we can advance the next balloon quite easily, as it disrupts the tissue within the stent. So we can see here now, this is I think this is a nanocross balloon, so which could cross mid of the stent, and then we opened it up, and subsequently my CORSAIR advanced into the distal RCA. So and then we took a support wire extra. Yeah, so in this case preemptively we used a guide liner, as we anticipated difficulty in sending IVUS catheter as well as subsequent devices across underexpanded stent here. So we have sent IVUS through guide liner, and yeah, so this is the IVUS, you can see here. So so distal to stent, it is nice. So now we reached within stent. You can see there is a dissection within the intima, which we created with the knuckle, and we can see there is a good expansion of this distal stent. In fact, that is also visible here in angiography. And as we came across, at some point, at this point, there is a clear under expansion of the stent. We can see here, yeah, this is all calcium, and there is an under expansion of whole stent also, and leading to intimal hyperplasia as well as total restenosis and total occlusion. And there is also calcium proximal to the stent, and so you can see here, yeah, Yeah, this is a distal vessel, almost 2.8 to 3.1, average of 3 diameter, and you can see this is in the distal stunt. There is a good expansion of stunt, nearly more than 8 mm square here, and here also it's almost more than 8 mm square. But when you see here, the point where the balloons got stuck and even the whites got stuck, this is the point where we can see there is a calcium, and there is also under expansion of the stunt. We can see it's at 6.7 mm square. This is post 2.5 balloon dilatation. So there is a clear under expansion of earlier stunt. Since it is a CTO, and since I created a huge dissection within the intima by my knuckle, so I have to basically go ahead with stunting. There is no question of simple balloon dilatation in this case. So, and this is the ostial thing. So what we did is we used an OPN-NC at this point, 3.5 OPN-NC. We can see here still there is some kind of a napkin ring here. So then I used a FLEXTOME at that point. So finally, post OPN-NC and FLEXTOME, so we could achieve a good luminal gain. You can see here it was before it was 6.7 mm square. That's a minimum stunt area. You can see here after OPN-NC and FLEXTOME, it is almost 8.8 mm square. So yeah, that's a luminal gain which we have got, and later on we stunted with 2 stunts, and this is a final result. You can see a good final result with a good distal flow, and all branches are flowing. So we did IVUS. Yeah, so this is the IVUS. You can see this is the distal reference area, which is 4.7 mm square, and distal stunt 9.4, and this is the site of calcium, where it is dilated up to 9.4, and this is at ostium, which is 11 mm square. So we have got good luminal areas all throughout the stunt, so which nearly says rich-nose chances are very, very minimal. Coming to the learnings from this case, any instant CTO, so CROSSBOSS is a good strategy, but position CROSSBOSS within the stunt before spin advancement. CROSSBOSS may not advance in certain situations like poor support, or if there is a neoatherosclerosis with calcium, focal under expansion of the stunt, which prevents CROSSBOSS advancement. And knuckle wire can be used in instant CTO. Before using knuckle wire, enhance guide catheter support. If there is no side branch, use balloon trapping of microcatheter technique. Start knuckling within stunt 5 mm beyond proximal cap, and also end knuckle preferably before distal end of the stunt. Never extend knuckle beyond the stunt edges.